All right, thanks for the introduction and thanks for having me here. Seems like another great year for the conference and excited to be a part of it. I'll be talking about the use of PRP and stem cells in sports medicine. So to begin, no financial disclosures related to this talk. And if you read any common press, PRP and stem cells is everywhere. These treatments can promise to do absolutely anything. Regrow hair, change your skin, dry eyes, self-image. It's endless what the possibilities are. In the field of sports medicine, we're also inundated with reports from athletes using these therapies. If this treatment can work for Kobe, can work for Tiger Woods, get them back to sport, of course it can be good for our patients too. Our patients often come in reading about these reports and having many misperceptions about the potential benefits. And so today I'd really like to go through the actual science, not what we see in these reports, and see what you really can use these treatments for. So an outline for my talk, we'll start by discussing platelet-rich plasma, going through the composition and how it's prepared, and then go through the evidence for common clinical applications for what I think we do have evidence for and where the evidence is really lacking. Next, we'll move to stem cell treatments, talking about bone marrow aspirate concentrate and adipose-derived stem cells. Again, the composition and preparation, and then followed by some early studies on evidence for clinical applications. And then finish with how to discuss these treatments with patients. My goals for this talk are to present high-quality studies when possible. I've tried to use primarily level 1, level 2 evidence, systematic reviews of high-level studies with a few case series here and there. There are a number of small series that we're not going to discuss here because the evidence just isn't quite as strong as other studies that are out there. I'll try to focus on injection-based treatments rather than surgical, but there is a whole other area of the literature talking about surgical treatments. And then I'll try to highlight the important details when evaluating these treatments in the literature on the topic. So to begin, what exactly is platelet-rich plasma? So very simply, it's a volume of plasma with a platelet count that's higher than baseline blood. The reason why this is important is because platelets contain various growth factors that are present in the alpha granules that have certain properties in stimulating tissue. So cytokines like TGF-beta, PDGF, VEGF, and others are in those alpha granules and at much higher concentrations. These are important for chondrocyte differentiation, vascular growth, wound healing, a number of other potential properties. And the concentration of these growth factors may be a powerful directed biologic treatment that we can use to address injuries and chronic conditions. So it is important to remember that not all PRP is the same. This isn't a standardized medication, and there are many different formulas. So there are pictures of 6 different commercially available systems here, and all of them will produce a slightly different product through a slightly different protocol, and those differences are important. On the table here, I have just a brief classification of types of platelet-rich plasma. There are a few other classifications, but I think this one conveys some of the main points. So pure platelet-rich plasma has high platelet concentration, no leukocytes, and then a low-density fibrin architecture. So the fibrin architecture is either the form of an injectable or the form of a clot. So if we're using this in the clinic setting, we want something that we can inject. Sometimes for surgery, a clot's advantageous. We can place that at the site where we want those growth factors and have it stay right there rather than diffusing into the space. You can also have leukocyte and platelet-rich plasma, which has an elevated leukocyte concentration in addition to the platelet concentration, or you can have the high-density variants of those two. There are also multiple patient factors that contribute to the PRP composition. So first, coming back from lunch, a high-fat meal increases the peripheral platelet count compared to fasting. The platelet concentration and aggregation properties vary with circadian rhythms. So the time of day that the patient gets this injection can actually influence the product that you obtain also. And concentrations increase in the afternoon, and activation decreases from noon to midnight. So if you're doing this in the morning versus midday versus afternoon, the product that you're getting is going to be slightly different. So to prepare PRP, this is something that can be done in the office and begins with a peripheral blood draw. The volume of blood that you draw from the patient depends on the system that you're using, but generally ranges somewhere between 20 and 60 milliliters. You need to use at least a 21 gauge needle. A smaller needle can cause premature platelet activation, so you want to have a larger bore. It should be performed slowly, so you prevent activation, and then it should be done with polypropylene tubes. Those show the lowest risk of premature activation and aggregation of the platelets. After the blood is obtained, then you centrifuge the sample to isolate the platelets. Most systems begin with an initial spin in the range of 1,200 to 1,500 RPMs, and this separates the platelets from the white cells from the red cells. You get that layer of platelet-poor plasma and platelet-rich plasma, and that can be your injectable. If you decide that you want a leukocyte-rich product, then you'll go on to a second spin that's optional and concentrates those white cells into the platelets. And then the final PRP is ready for injection. Again, you want to inject slowly using a 21 gauge or larger needle, and then do this without any local anesthetic, as the pH of the local can change the platelet aggregation properties. So in practice, the clinical use of these products is certainly increasing. We're seeing more and more, especially in older age groups, 50 and older, in a wide range of conditions: cartilage, muscle, ligaments, and it is a treatment that is often expensive and costly. So I think that we have to approach this with a clear understanding of what we can offer patients and what we can hope to do. The per patient average charges have been reported at around $1,700, and the cost for the patient ranges from $500 to $1,500 per injection. And this is usually out of pocket, not covered by insurance at this point. So the results for PRP in practice, I'll go through a number of different conditions next, starting with tendinopathy, so lateral epicondylitis, patellar tendinitis, Achilles tendinitis, and rotator cuff. Follow that with a brief discussion of muscle and muscle strains, and then ligament injuries, including UCL injuries and throwers and high ankle sprains, and then followed by knee osteoarthritis. So to begin, PRP for tendinopathy, the best evidence at this point is in lateral epicondylitis. So Mishra from Stanford first introduced this concept with just a case series of 20 patients. 15 were treated with leukocyte-rich PRP, 5 treated with bupivacaine. The symptoms were present for 15 months in that PRP group, 11 months in the control group. These patients had tried and failed other treatment and then trialed with PRP. And as you can see, the VAS pain scores improved notably in that 8-week time period for the PRP group, and that was not seen in the bupivacaine group. And the Mayo elbow score also improved significantly. And this really sparked the interest in using this for lateral epicondylitis. And since then, there's been a number of high-quality randomized controlled trials. In this one by Dr. Gozens, they included 100 patients, 51 patients treated with leukocyte-rich PRP, 49 in the corticosteroid control group, and with chronic lateral epicondylitis. And what they saw was similar results up to about 8 weeks, and then you really start to see divergence between the corticosteroid and the PRP group. The symptom relief and improved function was noted in the PRP group up to 2 years, whereas you started to see some recurrence in that corticosteroid group around that 8-week mark. Dr. Mishra also followed up his initial case series with a multi-center, double-blind, prospective randomized control trial, and this is in patients with at least 3 months of chronic lateral epicondylitis, 116 treated with leukocyte-rich PRP, 114 in the control group. At 12 weeks, no difference between the groups. Both saw benefit. But then at 24 weeks, we again see that divergence in the results. The top graph is just showing elbow tenderness with the bottom line, the PRP group. So 29% have elbow tenderness at 24 weeks compared to 54% in the control group. So we're really seeing a marked difference that really bears out after that 2 to 3 month period. The treatment success was significantly higher in the PRP group. Over 80% were successful. So again, this is more or less recalcitrant lateral epicondylitis, and we're seeing a lasting benefit from leukocyte-rich PRP injection. Moving into patellar tendinopathy, Little performed a systematic review of a number of comparative trials looking at PRP for patellar tendinopathy. Don't have a lot on patellar tendinopathy because the results are really mixed. We've seen some studies showing positive benefits, some showing no benefit, and so at this point, I think our best evidence shows that it may be promising. There is possibly some benefit. We haven't quite identified the patients who will derive that, but its superiority over other treatments such as physical therapy it's not proven yet. So PRP for patellar tendinopathy, still not really known what those effects are. Next, talking about Achilles tendinopathy. So Guelphi, they looked at 83 patients, and this is just a prospective study, non-comparative, looking at the effects of PRP, and followed their patients for 6 months. For an Achilles-specific patient-reported outcome score, they saw improvement. That's a VISA A score that you're seeing in that graph, and you definitely see improvement from baseline to final follow-up. And no ruptures, which is good. We're not causing harm with this treatment. And then 10% of their patients had treatment failure and required a repeat reinjection. So they concluded that a single leukocyte-rich PRP injection was safe and effective. But again, this isn't compared to any control group. In comparison to a control group with an injection of saline, however, we see somewhat different results. So randomized trial, 24 patients, 12 get PRP, 12 get saline. 13 patients discontinued this after 3 months because of poor results. In most of those, 9 out of the 12 in the PRP group had discontinued treatment. They had dropped out because they weren't happy with the results, whereas only 4 in the saline group dropped out. The 3-month VISA A score, no difference, but I would say this is a little more discouraging, that here we're randomized to saline placebo and really not seeing any kind of benefit, and actually almost worse outcomes in that PRP group. There have also been 2 larger randomized control trials on Achilles tendinopathy, DeVos and Young. In both of these, no difference in placebo and PRP injections. So at this point for Achilles tendinopathy, I think the literature shows us that it's not harmful. We're not going to cause increased risk of rupture, but we're probably not providing any benefit. And I think that as we go with further literature, perhaps certain indications come, but right now Achilles tendinopathy, don't think the literature can support the use of PRP in that condition. What about PRP for tendinopathy and partial thickness rotator cuff tears? I think this is an incredibly common problem, something that we don't have the perfect solution for yet, so hopefully a biologic treatment can help. This study is looking at PRP versus cortisone. In this patient group, there's a slight improvement at 3 months in pain scores and function, but then by 6 months, the groups were identical. Looking again at this PRP versus an exercise regimen, and you can see that these groups track along almost identically for a year, and there's really no difference between exercises versus PRP injection in the setting of rotator cuff tendinopathy or partial tears. So Fitzpatrick published a recent meta-analysis trying to summarize the data on PRP for tendinopathy in general. This included 18 studies, over 1,000 patients for a wide variety of conditions. And they reported that the greatest effect was seen with leukocyte-rich PRP, which is important to take away, and that there was a significant benefit over control. So the mean difference, 36 versus controls at 14. Leukocyte-poor PRP also was better than control, not quite as good as that leukocyte-rich group. However, I think when you really look at this study, 13 of those 18 studies were on tennis elbow. So I think that this may be we may be seeing the effects of the elbow injections outweighing those negative results in the other groups. So I think not all tendinopathies are the same. It's important to remember that when reading a paper like this. And I think that tennis elbow, we do have positive results, but the other tendinopathies, I don't think the literature is quite that strong at this point. So moving on to muscle injuries, just briefly have one systematic review from a group out of Toronto, and they summarized through a meta-analysis 5 level 1, level 2 comparative studies with grade 1 or grade 2 muscle strains, primarily hamstring, most common that I think that we're treating. And it was heterogeneous with regards to the PRP formulation and dosing regimens, so can't really pull the perfect regimen or formulation from this. And they noted a re-injury rate of 14% in the PRP group, 17% in the control group. So probably not much difference there. But the difference that they did see was PRP brought about an earlier recovery in that group by about 6 days. So for most of our patients, that may not matter. The cost of PRP for 6 days is probably not worth it. But I think if you're looking in an elite athlete, if you're looking somebody who that 1 week time frame may matter, that it does look like this can speed up that process of recovering from a muscle injury. So moving into PRP for ligament injuries. So first, Podesta looked at PRP for ulnar collateral ligament injuries. So with our throwing athletes, this is certainly something we're always concerned about. And I think these partial UCL tears are especially difficult to manage. Rest, anti-inflammatories, we don't always know what we can do to get them back without an operation. And so they looked at 35 high-level throwing athletes with partial UCL tears confirmed by ultrasound and gave them a single leukocyte-rich PRP injection under ultrasound. And 88% were able to return to play at the same level. And the average return to play was 12 weeks. And only one subject of their 34 went on to a UCL reconstruction. So they didn't compare this to a control group, but I do think this data is fairly encouraging. It's certainly an area of further research, but something to consider if you're dealing with throwing athletes with that partial UCL tear. High ankle sprains, Laver, their group, they looked at 16 athletes randomized to 2 injections of leukocyte-poor PRP that was activated with calcium chloride, or a control group treated with just a standard rehab program. And what they found was significantly different return to play time. The PRP group was able to return in 40 days, where the control group was able to return in 60 days. So again, if you're talking about a sedentary patient, 20 days may not be something that's much of an impact, but I think in the elite athlete, that almost 3-week time frame could make a difference. Additionally, residual pain was significantly lower in the PRP group. So this is a small study, but I think fairly encouraging results in this, this patient group. So next, PRP for osteoarthritis. So Brian Cole out of Rush published recently on a comparative trial between hyaluronic acid and PRP for knee osteoarthritis. Their final cohort was 99 patients split between the two, and their primary endpoint was the WOMAC score. And this pain score, they showed really no difference between the two groups at any time point. This is what they were powered for, what they were trying to detect, and their final pain scores were 3 in the PRP group, 4 in the HA group. But I think looking at the studies a little more closely can give us a little more information about how this treatment may be useful. So this first graph is showing the cytokine levels in the knee. And what we can see is the IL-1 beta and TNF alpha levels are significantly lower in the PRP group after injection. And this is maintained for a number of weeks. So that PRP injection, it does seem to be changing the synovial environment, and that may be beneficial. Additionally, this is the IKDC score. And so this score probably reflects more on function than the WOMAC score does. And you can see that the PRP score was significantly better, and this starts around the 6-week time period and then is maintained out to 1 year. So while the pain score may be similar, the authors were able to conclude that the patients receiving PRP seemed to be going back to a higher level of activity. They also noted that the PRP worked better in mild osteoarthritis, so KL grade 2 or better, as well as patients with a lower BMI. They were able to conclude that it lowers the pro-inflammatory cytokines in the knee and concluded that significant improvements were seen in other patient-reported outcomes with results favoring PRP relative to HA. There's a number of systematic reviews on the topic, including level 1 and level 2 evidence. And from this, so the figure up on the right side of the screen is looking at the WOMAC score, and we really see a trend toward leukocyte-poor PRP showing a benefit relative to both HA and control treatment. Again, the WOMAC score better with PRP in these large collections of data, and patient satisfaction scores better with PRP in this knee osteoarthritis group. So PRP for early arthritis, we do have level 1 and 2 evidence. And I'd say that it's likely beneficial with leukocyte-poor PRP. The results seem to last for about 1 year, and there's no evidence to support that this is doing anything in the way of structural regeneration. This isn't regrowing cartilage, regrowing meniscus, anything like that. It's probably working through that alteration in the inflammatory environment, and we have no long-term data on the natural history, like how these patients perform after that 1 year time period, but I think that this is what we can take from the current state of the literature. So next, just like to move into stem cell injections. So the rationale for stem cells, mesenchymal stem cells have potential to differentiate into cartilage, bone, tendon, and muscle. This may allow for targeted regeneration of tissue, and MSCs are present in bone marrow and adipose tissue. So there's a number of animal studies out there that support us looking into these cells as treatment in our chronic degenerative conditions. MFCs have been shown to improve functional scores in animals, regenerate cartilage, both focal defects and more diffuse defects. The problem is that there's a lot of animal literature out there that doesn't directly translate into our patients. So I think we need to be careful in just extrapolating that to human clinical trials. Two primary sources for stem cells. So the iliac crest is an excellent one, and this gives you bone marrow aspirate concentrate. So using a large needle, you're able to aspirate 60 to 120 milliliters. The stem cell yield is 0.01 to 0.001% of the cells obtained, so fairly low. A newer treatment is adipose-derived stem cells, and this is obtained just basically through a liposuction type procedure. 17-gauge needle, you insufflate the abdomen and then aspirate the lipoaspirate from the abdomen, and usually extracting 80 to 120 milliliters. And reports have shown up to 10% of the cells here are mesenchymal stem cells. So this may offer some promise too. The clinical data so far on this end is fairly lacking, so don't have a lot to go through here, but this study looked at 18 patients with knee OA treated with low, medium, or high dose of mesenchymal stem cells, adipose-derived, and this was followed by a knee scope and lavage, and saw improvement across the board, no adverse events. Again, they didn't have a control group, and I think I've included Sandy Kirkley, one of the landmark trials on comparing sham knee scope to a real knee scope, where showed the sham knee scope had about the same performance, and I think that's about what you see with their injection too. So before getting too excited, I would want to see this compared to a true control, because I think it's what we've seen in the past with placebo-type treatments. Looking at bone marrow aspirate, this was a systematic review, just looking at level 3 and level 4 studies, so not great data. And they conclude that the treatment appears safe. It doesn't seem like we're doing harm, but no data to recommend dosing, aspirate amount, or efficacy. So here the data is really lacking, and I think pushing too far forward at this point is something that should be done in more of a research setting than routine practice. So we've talked about a little bit limitations of the studies. Many have no control group. It's hard to interpret the results of these experimental groups without that control group to know exactly what we're doing. And there's inconsistent reporting of the exact formulation of the biologic treatment. These aren't standardized like a pill, and they do vary, so I think that we do need better reporting of what's in them with regards to the cytokines. And when interpreting these studies, I would just recommend paying attention to the injection protocol, the presence or absence of leukocytes, and the control group comparison. So quickly to how to discuss these with patients. Oftentimes we get questions, will PRP stem cells regrow cartilage? Will it regenerate my meniscus? Can this keep me from getting a knee, hip, shoulder replacement? And they'll find pictures online here that show a before and after these miraculous injections that your arthritis is gone, your joint looks normal, but this is all not true. And I think that we do need to make sure that we tell people in a straightforward manner that these aren't magic and it's not going to change your joint structure. So how does it work? I think likely the pain relief is through that modulation of the inflammatory process. It's unlikely to change the structure with an intra-articular injection. I think for the tendon type indications, you're modulating that inflammatory response to get back to normal tendon, but this isn't changing structure in joints. And then what about the cost? So most treatments are out of pocket, they are expensive, and there is a limited duration of relief with most treatments. And I think letting the patient decide, is that potential 1-year improvement in function, maybe the same pain, is that worth that out-of-pocket cost to them? I think some will say yes, some will say no based on their circumstances. And then I think offering these patients the opportunity to participate in a clinical trial will help advance the science and can often help the patient too. So my recommendations to finish up. So I do think that the evidence is there to support leukocyte-rich PRP for lateral epicondylitis with more than 3 months of symptoms. I would consider PRP for elite level athletes with a high ankle sprain, a partial UCL tear, or grade 1 or 2 muscle strain. And these we're probably looking at a short improvement in return to play rates. So for most patients, this doesn't change your final outcome, it just gets you there quicker. And I would consider it for early knee arthritis, providing the patient with all this information if they've been unresponsive to HA injections, steroid injections, and are willing to go forward with it. We don't have current data to support routine use, and better data is needed for the other tendinopathies, as well as the role of BMAC and adipose-derived stem cells. So these treatments hold promise as a potential treatment option for various conditions. Not all formulations are the same, though, and high-level control trials are needed before we can really recommend these on a widespread scale. So thank you. I'd be happy to take any questions.